concussions are one of the most complex injury a person can sustain, and everybody's symptoms are different. And so people really need an individualized treatment plan, which is something that our mainstream medical system doesn't always have the capacity to do very well. So we've got an increased amount of awareness, and we've got an increase in taking precautionary steps to make sports safer and to make vehicles safer and to make buildings safer.
I'm Michael Max, and this is Geological, the podcast that curates East Asian medicine and methods through the power of conversation. I get this question a lot in clinic. You probably do as well. How do you know where to put those needles? It's a good question, isn't it? So, just how do you know where to put them? Are you following a map in your mind based on words written in a book? Maybe following the advice of someone you don't really know on Facebook? Relying on your patient's response to the last needles that you used that helped them? Or are you following the unfolding of presently encountering your patient? Palpating to see where it's cold or hot, where the tissue feels gummy or soggy with water. Just what is it that you're attending to, and how do you translate what you feel into a decision to insert a needle? I find this question from patients about where do you know where to put the needles to be a question that parallels one of my own. The question that set me off on the path of learning the trade, and the one that keeps me doggedly on it, which is, how does acupuncture work? Yes, I understand there's modern research, MRIs, and ways to measure biochemical responses to needles. There is that thing about the fascia, the great connective spaces of the body that weave together what seems apparently to be separate, and its piezoelectric sparks when needled. There's the inquisitive dissection work that shows the nerves that inhabit acupuncture points. All of this is of interest. It tells us something of the structure and function and makes for helpful marketing material when you want to science up your acupuncture. Then there are the old books, stuff passed down through generations and given credibility via the stamp of historical approval, along with the validation of if it didn't work, it wouldn't have been passed down. If something is useful, it would have a tendency to perpetuate over time. There are multiple maps that chart the terrain of acupuncture. For the most part, they all have some use and merit, I suspect, because they help guide the practitioner in how to use our attention. It's less about that the map is right, and more that the person using the map is able to accurately and coherently attend to the reality of the patient and their situation. How do I know where to put the needles? It's like knowing how much salt to put into sauce. If there is a space to make a left-hand turn in traffic, whether a cat wants to be petted or not, it comes from knowing the look of sky and scent of the wind that it will rain, or mood of your spouse that says, bring this up later. These choices are made up of what you know, what you feel, and what you're being told to do when you're using your attention instead of your intention. How do you know where to put those needles? It's a question we have to answer every day with every patient. It's a bit like knowing how to jump into a conversation and ride the rhythm of it. And that means you need to know the lay of the land, the context, and the situation. When it comes to neurological issues, and in particular concussion, there's a lot to that landscape. In this conversation with Ayla Wolf and Clayton Shiu, we follow Ayla into the Alice in Wonderland neurobiology of the brain. There's a lot more to concussion than wind and blood stasis. We also explore with Clayton the palpable changes you can feel on the skull that are indications of neurological pathology. The classics say the brain is a curious organ. It certainly is, and these two have been mapping the territory that will indeed help you with knowing where to place a few needles. We'll get into it right after this. Qiological Conversations come to you through the generous support of our sponsors and members. You have clinic challenges? Our sponsors have solutions. This month, Mayway Herbs focuses on formulas and resources for women's health. Have you ever wondered about the fast and AcuFast? Listen in and find out. And later in the show, Jane helps you to organize the modern acupuncture practice, and Blue Poppy reminds us that there's no such thing as a small detail. Do be sure to visit the sponsors page on the Qiological website to take advantage of all the special offers our terrific sponsors have for listeners of the podcast.
Hi folks, I'm Yvonne Lau, president of Mayway Herbs. During the lovely month of May, we're happily focusing on women's health. You can enjoy new articles and our Chinese Medicine Matters podcast on topics including menopause and perimenopause, optimizing fertility, and how to differentiate between formulas that tonify blood and warm the uterus. We'll also explore more complex presentations, like hyperemesis, with practical, pattern-based insights to support your clinical decision-making. And check out our helpful comparison charts and discussions on Mayway.com to aid in optimal formula selection. This month, clinicians can enjoy special savings on formulas that support blood, fertility, and menstrual health. Since 1969, Mayway Herbs has supported practitioners and their patients with high-quality herbal products and trusted educational resources. So visit Mayway.com to learn more. Have a wonderful spring season, and thanks for supporting real Chinese medicine.
A busy acupuncturist knows that saving time is a big win. Have you heard about AcuFast earth-friendly needles? The fast in AcuFast isn't just marketing, it's what happens once you learn the system. And that takes about 30 minutes to retrain your muscle memory and reorganize your workspace. But after that, you start saving time every single day. This is John Stan, inventor of the AcuFast needling system. At a recent conference, a practitioner told me he used to spend about 6 minutes per patient opening needle packs and inserting needles. With AcuFast, he said, that dropped to 3 minutes. Yep, he was that kind of busy. In his clinic, that added up to an extra hour every day. Just think about that. Enough time to treat another patient, catch up on charting, or simply finish earlier. That's why it's called AcuFast. It's just faster. And with earth-friendly packaging, you're reducing waste at the same time. Less waste, more time. AcuFast, faster for you and lighter on the planet. Visit acufastneedles.com to learn more.
Clayton Shiu, Ayla Wolf, welcome back to Qiological. You both have been here before. It's wonderful to be able to sit down with you again.
Thanks for having us.
Yeah, thanks for bringing us back. It's exciting. Together, too. Yeah.
We're all together. And we're all together because you guys know a thing or two about neurology, both from a Western point of view and, more importantly, a Chinese medicine point of view. And today we're going to be jibber-jabbering a bit about something that most folks see in their practices these days. It's like it's become a popular thing. When I was a kid, people would talk about this, but we didn't take it very seriously. I don't think we even knew much about what it was. These days, it's important. We're going to talk about concussions.
Yeah. It's definitely a big topic now, and it's hitting everything from sports to younger people and older people and across the country, right?
What has made it become, I'm going to say, this is just a funny way of talking, but like, what's made it so popular? Why is it in people's awareness? Why is it on like school forums? Like, I guarantee my kid has not had a concussion. Sometimes for kids to go to school, you've got to give a concussion history to the school. And it's like everywhere these days.
Yeah, I think part of that is when the movie came out called Concussion, which was the movie starring Will Smith, and it was about the researcher who was studying chronic traumatic encephalopathy. And then you've had several high-profile football players who have committed suicide in a dramatic way where they shot themselves in the heart so that they could preserve their brain so that science could study their brain. And so when you get that kind of traumatic event with a high-profile individual that's all over the news, all of a sudden you have a lot of parents that become very concerned about their kids' well-being playing different sports. And so I do think that since that movie came out and which was kind of based on a book called The League of Denial. And then you had all this information coming up about chronic traumatic encephalopathy and the NFL. So many people in this country play football or hockey or even cheerleader. Cheerleading is another sport where there's lots of concussions. But so you have a lot of people playing sports now, and you've got increased interest in safety. You know, just like we are always constantly updating our vehicles to make our vehicles more safe, we're trying to update the rules in different athletic sports to make them safer as well. And so the awareness has increased dramatically. And yet at the same time, the problem is that concussions are one of the most complex injury a person can sustain, and everybody's symptoms are different. And so people really need an individualized treatment plan, which is something that our mainstream medical system doesn't always have the capacity to do very well. So we've got an increased amount of awareness, and we've got an increase in taking precautionary steps to make sports safer and to make vehicles safer and to make buildings safer. And yet at the same time, when people do get a concussion, if they don't heal on their own, which, you know, the research says 30% or more people go on to have persisting symptoms beyond kind of an expected several week time frame, those people often kind of get lost in the medical system, or maybe they exhaust a lot of pharmaceutical options that aren't helping. And that's where a lot of times those are the people that end up in our clinics, are the people who have already exhausted a lot of other treatment options and they're still symptomatic.
Yeah, I agree with that. And also, like, I think as the decades have worn on, like, there's much more metrics today that we can tune into and almost measure and see a little more objectively the nuances within a concussion and brain functionality and cognitive factors that we just didn't have back then. I mean, you know, today everyone's wearing practically like an Aura ring or a Whoop, or they're measuring their steps. There's, you know, whereas before when someone got injured, like, do you feel okay? Okay, get back on the field. All right, you're good. Yeah, I'm okay, coach. You know, I can walk, you know, but no one checked, you know, their parietal lobe. No one checked, like, on the field, you know, their vision. They're just seeing, like, you know, is your arm broken? Okay, let's go back in. So what's also been happening throughout this whole, like, century is that the people that are neurologically in tuned have developed, like, very advanced hands-on palpatory and like even not using a machine, but a way to functionally analyze the neurology of a patient or someone that may be having concussion or may be having brain fog, etc. And I think the more attuned you are to that and you're aware of it, it's almost like you see something you didn't see before, basically. And now it's like reaching, like what Ayla said, because these public figures, they get injured, it brings attention, but the veil is like lifted, you know, just like with stroke and Christopher Reeve. Like, if he didn't have that horse accident, you know, equestrian accident, no one would have done more research on neuroplasticity, right? So, and he funded the research for that practically. So now I think today we see even more research analyzing different helmets for football players and all this other interesting stuff too.
Yeah. So in part, it's awareness. Ayla, oh my God, you know, you mentioned football players shooting themselves in the heart so they can preserve their brain for research. It just like brings tears to my eyes thinking about that kind of suffering and that kind of awareness and desire to be helpful. It's incredible. And yeah, there's more research. I mean, look, as time goes on, things get better. You know, medicine gets better, diagnostics get better. People that are paying attention to whatever thing they're paying attention to, they get more experience, notice things. I'd like to make this, in some ways, I'm interested in the theory neurologically and the theory with Chinese medicine as well, but also very interested in just hands-on what we can do for patients in our clinic, for kids that bonk their head, you know, for us, if we, you know, get a knock on the noggin. What are the Western screenings, like initial Western screenings, that you would expect people to get? How are they helpful, and what are they missing that we might be able to bring in with Chinese medicine?
Yeah, well, and I think before we get into that, I do just want to say that post-concussion syndrome is not chronic traumatic encephalopathy. And so I think a lot of people, I don't want to worry people in saying that, if you have post-concussion syndrome, that means you have chronic traumatic encephalopathy and it's going to turn into that. So I want to make sure I'm not misguiding people. Those are two very different things. And chronic traumatic encephalopathy, the research is pretty clear that it really seems to come from people who have had repetitive subconcussive and concussive hits to the head over time. So again, in football, obviously there's a great risk, but also with like domestic violence situations and women who have been repeatedly hit in the head. Sadly, we started studying men and chronic traumatic encephalopathy, which used to be called punch drunk syndrome way back in like the 19s. And it wasn't until honestly like 10 years ago that a coroner actually started dissecting a brain of a woman who was in a domestic violence situation. And so some of the very first case reports of women with chronic traumatic encephalopathy, literally it took us 100 years to be like, hey, what about women? So there's a lot that needs to happen in regards to even assessing the brains of females and understanding the difference between men and women and these effects. So I just wanted to kind of say that first, but then typically, when somebody gets a concussion, they will go to, urgent care, ER. At that point, they have a set of criteria that they use. There's something called the New Orleans criteria with which to determine whether they need to do a CT scan, because you don't want to do a CT scan if you don't have to. There is some research that says that they increase the risk of brain cancer. And so you don't want to just willy-nilly be running brain CT scans if you don't have to. So there are criteria that they follow in terms of people's symptoms to determine if it's to do that. That CT scan is simply assessing for whether there are fractures to the skull or internal hemorrhaging, like a subdural hematoma or some kind of bleeding in the brain. And so it doesn't diagnose a concussion. It simply rules out more serious issues that might need more emergency medical care. And so there's some pretty dismal research that does say that once somebody's been in the ER, what happens after? Many people don't follow up with their doctors. So they get a concussion. Maybe they don't think that it's all that serious. Maybe they just assume they'll get better. And so in many, many cases, the research says people tend to not follow up appropriately with any kind of provider after they've been told your CT scan is normal. So a normal CT scan is not diagnostic. It's simply just ruling out other issues that might need further emergency medicine. After that, it's really, an issue of where does that person end up next and how concussion informed is the provider that they see. I would say it is pretty common that if somebody's having balance issues or vestibular issues, their doctor will refer them to a vestibular PT. And then same situation, it's up to how well trained is that vestibular PT to be able to diagnose and treat some either complex vestibular issues or issues with like an integration between the ocular motor system and the vestibular system. And so that's where, again, people are really at the mercy of the individual practitioner and their level of knowledge and being able to do assessments and then figure out how to treat what they're seeing. And that's going to be different for every individual in terms of what they're dealing with. And so that's where things can go awry if maybe somebody ends up with a clinic or a provider who's not highly concussion informed.
Would it be fair to say that there can be symptoms from post-concussion that haven't resolved, and they'll kind of masquerade as problems, like you were just saying, PTs doing vestibular therapy. It's like, oh, well, there's a vestibular issue. We're going to treat that, thus overlooking, oh, there's a concussion that's at the root of this.
Yeah, I mean, a lot of times we call these like they're like false symptoms of patients that may have vestibular issues or they may have tinnitus or even gastritis. Okay, so you can have these different other functions of the body and this patient comes in and you think, oh, this is another digestive patient or someone that has like ringing in the ears. But actually, if you put in your basic set of analyzing the brain and concussion protocol, you can actually figure out that, oh my God, this isn't gastritis or tinnitus at all. This actually could be a brainstem injury. And because it's controlling these autonomic functions of the body, it's manifesting as other types of patterns or cases that we see. But actually, it's a concussion that's masquerading as other symptoms or other complaints.
How do you go upstream on that to figure that out?
Well, when someone comes to me, I spend 2 hours up front running them through a lot of functional tests. And I start by having them fill out a pretty lengthy questionnaire that is divided into kind of specific symptom categories. So there's this concept called a concussion phenotype, or when somebody gets a concussion, how is that manifesting in that individual? And so what I've done is I've divided categories into post-traumatic headaches, traumatic neck injuries, dysautonomia or autonomic nervous system dysregulation, cognitive symptoms, ocular motor symptoms, vestibular symptoms, sleep dysfunction, mood dysfunction, and then I have another category that I kind of just label as brain inflammation. And so when people come to my clinic, I have them fill out this very lengthy questionnaire. So very quickly, I get to zero in on what are this person's symptoms. And if they're coming in with a lot of autonomic nervous system symptoms, well, then I can have them fill out the Compass 31 questionnaire developed by the Mayo Clinic that also kind of dials into how severe is their kind of level of dysautonomia. And then I can run them through all kinds of functional tests where I do have, a tilt table. So I can look at someone's heart rate and blood pressure laying down. I can tilt them up and do a tilt table test. I have a pupillary light reflex app that takes pictures 30 times a second to give me a very high level printout of what their pupillary light reflex looks like. I run them through a bedside Valsalva test and deep breathing test to assess for vagal nerve function and parasympathetic tone. And then I run them through a 5-minute sustained hand grip test to assess for their sympathetic output. And so together I can look at all this data and say, how is the parasympathetic arm of their nervous system working? How is the sympathetic arm of their nervous system working? And to what degree is this autonomic dysfunction maybe driving their headaches, driving their nausea, driving their light sensitivity? And so once you kind of see how everything is connected, your examination really starts to guide you. And so, I might focus on autonomics for one individual, but for another individual, the majority of my exam might really be diving into how their ocular motor system is working and how their two eyes may or may not be working together properly, and how that might be driving their balance issues and their vestibular symptoms. And so it's like I'll do a vestibular assessment, I'll do an ocular motor assessment, I'll do a cervical assessment of the neck, we'll run people through sensory and motor testing. And so you really can't just look at someone's symptoms and know what part of the brain. It's like those are the clues that guide you to doing the test, but the exam is really what tells you, okay, here is what is working, here's what's not working, and then how do we craft an individualized program for this particular person based on their actual examination findings.
Wow, that is extensive. It sounds more, I was going to say conventional medicine, but like beyond conventional medicine.
It's the functional neurology background that I have that is where I learned how to do all of that stuff. But the beauty of it is that in the process of gathering all that information, you then get to see the power of acupuncture, because if you know that, gosh, when somebody tilts their head back into the left and they try to do a motor movement where they touch their nose and they touch my finger and that whole motor system breaks down, if I do some, vestibular rehab and some acupuncture, then all of a sudden everything improves. It's like I've been able to show the patient hey, look, we just made you better in one session. And so by doing the exams ahead of time and gathering all these individual data points, you start to really track whether or not your acupuncture is actually doing anything for the brain or not. And honestly, it keeps me super honest with myself in knowing whether or not I'm actually helping somebody.
Yeah, it's like taking the pulse in the beginning, it feels a certain way. You do some acupuncture, pulse feels different. Okay, something happened. I get the importance of getting to the root of things. Absolutely. Most of us in our clinics don't have all the wherewithal that you do for doing the kind of testing. Are there things that we can do with our Chinese medicine diagnosis, our Chinese medicine acupuncture perspectives that allow us to work maybe downstream, but have an eye toward what might be upstream? Is there some way of putting these things together?
Yeah, she's probably gonna cue me on what I. So, um, after after I got back from China and over the years of treating different sports injuries, and then collaborating a lot with with Dr. Wolf here, um, I started to collate and take all these observations, and I developed like a skull palpation method that, just like with pulse reading, it's like skull palpation. So as you touch and go through the different lobe areas of the skull, the different bones like the parietal bone, the temporal bone, the occipital bone, I've actually managed to categorize so that you can get into the target region of what's affecting the brain neurologically and diffuse whether or not, or differentiate whether or not, okay, am I dealing with concussion or COVID-19 brain fog or Parkinson's or like deficient headaches or excess headaches, etc. So it's a way that like we can get into very close in alignment with everything that Dr. Wolf just said, but also tie in as you palpate which points you may use. Like you may use gallbladder 20 in a different angle depending what you're palpating, or gallbladder 8. We use that a lot for the vagus nerve, and also to help actually treat different like tinnitus or different even memory issues too. So there is a way to actually learn how to palpate the head and the neck, and I use it like as an extra new innovative pillar to like pulse and tongue. So sometimes when I have like a neuro case or a concussion case, I may actually not do the regular pulse and tongue, but I may coincide or correlate it with palpating the head, and then pick specific acupuncture or organ points that can correlate to it. And just to add to what Ayla just described and everything, as you get more familiar with these presentations and the different like symptom categories that you're looking at, it's hard to explain, but it starts to crystallize in your mind, basically. And not only that, it can crystallize in your mind and also correlate with your understanding of TCM and meridians very well. So this is a good example. And this is more of a good way to look at it in terms of this case, is let's say someone did come in and they had like they complained of gastritis and irritable bowels, right? And they were given like different Western medicines for their stomach, and like to clear that up, and it didn't work. But then as you're doing your differential diagnosis, they'll tell you something like, well, my symptoms are still there. They didn't find anything in any like biopsies or cultures. But when I sit versus stand, my blood pressure drops. Okay. And someone that has digestive issues do not complain about any kind of blood pressure changes or getting light headaches. And when you hear that, you then want to refocus back to the neck, back to the head. And then when you just ask them, well, were you in a car accident like, a few months ago? And they'll tell you, yeah, I was, but I was fine. I didn't have any symptoms. I didn't have any whiplash, even though we know whiplash always happens like a week or two later anyway. So, but the lingering symptoms of having an injury to the head, it was there. And then it was affecting the person's digestive system and affecting them at night and giving them a little bit of tachycardia and stuff like that too. So all those funny, interesting symptoms that we may chase and be like, okay, well, that was like that was like heart fire, and that was affecting the spleen, and should it be guipi tongue? But actually, it shouldn't be. You need more of maybe a formula like Gogun tongue, or do more cupping and get into that neck area, and then in like 5 sessions, everything starts to dissolve, and the person's like, "Wow, my gas is gone, and I'm feeling better. I'm not getting these blood pressure changes. It's happening, and these areas start to change." And then it crystallizes. You could see it. So it's pretty interesting.
When running an acupuncture practice, treating patients is one part of the job, and managing your clinic is the other. That's why I rely on Jane. When I was first starting out, I had no idea about the office management structure I would need to support my acupuncture practice. It was not something taught in school, and let's face it, when I started my practice, life was simpler. Today's patients expect the offices of their healthcare practitioners to be automated, and as practitioners, we demand an office support system that fits our practice like a finely crafted tool, which is exactly what Jane does. Scheduling, charting, automated reminders to patients, payment processing, and even assistance writing clinic notes with AI Scribe are part of the kit. And for me, the peace of mind that comes with knowing that everything is working properly is why I'm delighted to have Jane handle all my office management. See how Jane can help you too by visiting jane.app/demo. Sign up for Jane and use the code CHIOLOGICAL to get a 1-month grace period on your new Jane account. So you have a map at this point of like a palpatory vocabulary of the skull that leads you to understand there's something happening with the brain here, there's something happening with the brain there. You've got markers for Parkinson's, you've got markers for tinnitus, you've got markers for concussions.
And dementia, and also even like patients that mentally push themselves harder. I call this palpation pattern the alpha CEO. It's just someone that
What do you find on the alpha CEO? What are you palpating?
they won't let themselves sleep anyway. Well, it's funny when you palpate behind the ear and then towards the mastoid process, you'll feel these ridges that are kind of hard and smooth. And and so if you're yeah, I know. And if you feel that, okay, that's not bone tissue, that's just the fascia and the layers there that are like that anyone who's running their own business or anyone that is the CEO or executive of a company, they're going to get these harder ridges. They're going to sound like they almost are going to be a case like a concussion, but they're actually reporting in almost like vague tinnitus or vague like functional focus issues instead. And the funny thing is if you slow them down and just start needling around that area, their symptoms start to clear up, and they can actually take a breath, they can relax better, so it's pretty interesting. Yeah, and some of the patterns that we even discovered with COVID-19, they would appear like in the back sinuses of the occipital area. And I think Ayla and I, we had a discussion about like we're starting to see all these orthopedic cases that weren't getting better, but they were actually people that actually had COVID also. And if we added these points behind the head, their orthopedic patterns improved because the pattern of how the COVID-19 was affecting the Tai-yang channels was kind of widespread. So that's why you were seeing all these interesting neurological new patterns, I would say, we were starting to see.
So like with COVID or with the alpha CEO, these are in a sense external changes that are happening in the tissues because these people are tight and their gallbladder channels tight and their triple burners tight and their go. And so there's something happening with their, or in the case of COVID, Tai-yang channel gets affected. There's something happening on the outside with the physiology that pulls on the skull and that has an effect on the brain. Is that what you're saying?
Yes, and it can work both directions too. So, yes.
As we know from working with acupuncture, things can come from the inside or the outside. or, some kind of combination.
Yeah. And because Ayla and I, we co-treat together, sometimes at her office, sometimes at my office. It's really fun because we'll do both methods and see it light up and see that, okay, neurologically this is actually correlating too. So it's almost been battle tested, I guess you could say, in the clinic.
Well, you're cross-referencing. You're cross-referencing a palpatory system with the incredible diagnostics that Ayla has in her office.
Yeah, she's got so much. It's such a high volume of off the chart diagnostic information that I had to create this new palpation and I'm trying to keep up with her.
Yeah, well, it's good to have challenges like that. You mentioned something a few moments ago that I was not aware of, that whiplash can come weeks later after an incident and not necessarily at the incident. Can you tell me more about that?
Yeah, do you want to talk about that, Ayla?
Yeah. So there's a couple of things that can happen if somebody has a neck injury. And one of them is that we have mechanoreceptors in our joints and in our muscles. And so when those mechanoreceptors are injured, they can send incorrect signals to the brain about how far and how fast the neck is moving. And our brain always wants to know where we are in space. And it does that by triangulating information coming from our visual system about where we are and how we're moving our head. It comes from how the information our neck is telling us. And then it comes from the receptors in our inner ear and our vestibular system, as well as the jaw. There are some feedback loops from the jaw back into the cerebellum that play a role in flexion and extension of the neck and our balance. And so when somebody injures their neck, the brain is constantly trying to figure out where am I in space. And if it's constantly receiving sensory errors from one system, eventually that causes problems if those sensory errors never get cleaned up, so to speak. And so if we lose what's called joint position sense of the neck, where our neck proprioceptors are not giving accurate information to the brain is constantly basically receiving a math equation where 1 + 1 + 1 no longer equals 3. And over time, that sensory mismatch can lead to the development of ongoing balance issues, proprioceptive issues, disequilibrium, headaches, nausea. A whiplash injury can by itself cause like blurry vision and a lot of these symptoms that are common with concussion. So there can be a huge overlap between symptoms from a traumatic neck injury like whiplash and a concussion. And so usually when somebody gets a concussion, there's usually an element of a neck injury involved in that. So now people are getting kind of problems coming from both the concussion and the traumatic neck injury. And you've got to be able to see that as you have to treat both. You can't just ignore one and treat the other.
So it's not just a bonk on the head and the trouble that causes. The neck itself is sensory rich and part of how we keep ourselves upright and balanced and oriented in time and space.
Exactly.
And if that system gets, I'm just going to say, a little noise introduced to it because of an injury, over time, the system becomes dysregulated.
Right. And acupuncture points on the back of the neck are a phenomenal way of improving that joint position sense and cleaning up some of those sensory errors and that noise that you're talking about.
Wow. So you find that in that case, for that problem, local treatment would be more useful than distal treatment?
Yeah.
That's a good spot for local treatment.
I have this pair of glasses that has a laser right in the middle of between the two eyes. And so we've got a chart on the wall where we can have the patient close their eyes, we turn their head, and they have to try to line the laser back up on the center dot. And so we can test their joint position sense when they're moving their head right, left, up, down, and in these diagonal planes. So we can get objective data on how accurate their proprioceptive system is for neck movements. And then we can treat them using local acupuncture and retest them. And we see really incredible improvements in their ability to know how far and how fast their neck is moving and to be able to control that.
Your clinic sounds like a playground.
Sure, yeah. It's got lots of tools, lots of tech.
I mean, it really sounds fascinating. You've got all these different tools and tests, ways of working with technology, tilt tables, glasses with lasers, that help you to get a sense of what's actually going on with this person. It sounds like a lot of fun.
You should come hang out.
I like, especially the goggles that record the eyes moving, right? So that's...
Yeah, the infrared goggles I use all the time.
So I've got a question, and this has got me thinking in all kinds of directions. It's not unusual because with doing acupuncture, we will often ask, well, when did something start, or how did this come about? Sometimes asking, well, did you have an accident, a fall, a concussion, or this or that? Many times people have forgotten that something's happened. I'm realizing I need to ask these questions more often in clinic as we're having this conversation. One of the things that I've noticed in my practice in the past, I'm going to say a year or two, are weird balance vestibular issues. Like, they just kind of arise for people.
Do you want to take that one, Clay? Well, the vestibular system is very complex, and a lot of attention gets paid to the most common reason that people get vertigo, which is benign paroxysmal positional vertigo, BPPV. Now, BPPV can be tested with using infrared goggles and placing people in different head positions to see if nystagmus kicks in. And in many cases, when people have some strange vestibular symptoms, they don't show that they have BPPV. And so that's where a lot of times some of the physical medicine people say, okay, well, you don't have BPPV, so maybe let's just try to let's just practice balancing exercise and see if your balance gets better. So I think that there are cases for if somebody just is not athletic and they're maybe decompensated because they've been a couch potato, practicing balance to improve your balance is going to work. But in the case of a concussion, usually there's other things going on where if you can't balance, just simply trying to practice balancing isn't actually going to get you where you need to go. And so when people have vestibular issues in my clinic, I have to assess the vestibular system first by itself, and then I have to assess it in the context of other issues or like other scenarios. And so when someone comes in, I'll put the goggles on them, which give me the ability to look at their eye movements when they're in the dark and their eyes can't fixate on anything. And if I have somebody looking straight ahead, so like for example, I had a patient come in, she was having episodes of vertigo. She had been to a nurse practitioner, she had been to a physical therapist, she had vertigo for 4 years, people didn't know why. She came in to see me, and I put the goggles on her, and right away, her eyes were constantly being pushed to the left and correcting to the right. So she had a right beating nystagmus. And in the course of my treatment, I saw her nystagmus change directions 4 times. It went from a right beating nystagmus, and then she had a couple of up beating nystagmus, and then she had left beating nystagmus, and then it turned back to a right beating nystagmus. And in my mind, I'm thinking, okay, there's really kind of like a few conditions that would cause this level of nystagmus changing directions like that. One of them is spinocerebellar ataxia. And so that's a pretty serious neurodegenerative condition. And I did have a patient who came in and I saw her nystagmus changing direction and she had ataxia. I referred her back to her neurologist. They did a brain MRI and she was diagnosed with spinocerebellar ataxia. So I take these things very seriously. And when I see something that's a red flag, I'm sending that patient out for the brain scan. Like, I don't mess around. And so with this patient, I did the same thing. I said, because this is what I'm seeing, because you're in your 60s, because, you've had this for 4 years and you've got some cerebellar signs as well, let's get you back to your primary doctor. They ordered the brain scan. The brain scan came back normal, which meant I got the green light to essentially treat this as a vestibular migraine, because that's the other condition that can cause nystagmus to change directions. And so I started treating her for vestibular migraines, and we got her phenomenally better. And it was through a lot of acupuncture. It was through a lot of peripheral nerve stimulation. It was through a lot of what I call head-eye vestibular rehab. But so a lot of times what we've discovered is that people that have vestibular symptoms, they often don't have a clear diagnosis. So that happens all the time. The other thing that confuses people is when we have something called like the non-spinning vertigo symptoms. So these are the symptoms where people say, I feel like I'm on a boat. I feel like I'm kind of rocking or swaying or I'm bobbing. And then they feel kind of a sense of disequilibrium when they're walking. Maybe they kind of have a pulsion to the side, like they walk down the hallway and they drift off to the right. Or when they spin around to come back down to walk towards you, then all of a sudden they're off balance too. And so we have to recognize that vestibular symptoms may be coming from the semicircular canals, or they may be coming from the otolithic organs in the vestibular system, which determine translational movements forward, backward, side to side, and up and down. And so in many cases, when people say that they're having dizziness or vertigo, I immediately ask many more questions, because people will say they have vertigo when they're actually experiencing dizziness or disequilibrium or rocking, bobbing, swaying, or they might use the word dizziness when they're having true vertigo. And so you have to make sure that the patient is not leading you astray by using the wrong medical term. So I really make sure that me and the patient are on the same page by asking a ton of specific questions on what their actual symptoms are. And then you can actually test these things where if someone's sitting in a chair and their back is not resting on the back of the chair and their feet are on the ground and their hands are on their knees, when they close their eyes, you can immediately see whether they're suddenly swaying side to side or swaying forwards and backwards, or maybe their head is kind of doing this circular movement. And so a lot of times when people say they feel like they're on a boat, when you have them sit in a chair and close their eyes, you see it. You see it kick in. And so then I run them through a lot of otolithic testing where I might tilt their head to the right and see if those symptoms get worse or better. And I tilt their head to the left and I see if their symptoms get better or worse. And then I'll lean their whole body to the side and see if they can maintain this 30-degree tilt. And I'll test for what we call subjective visual vertical to see, do they know what perfectly up and down actually is? And so there's all these ways that you can functionally assess the vestibular system to understand, is this a peripheral vestibular issue? Is it a cranial nerve issue? Do they have an acoustic neuroma, a tumor growing on their 8th cranial nerve? Or is this a centrally maintained vestibular dysfunction, like the case of a vestibular migraine? And so being able to understand, am I treating a peripheral problem or a central problem is very important. And it's amazing just how many people are walking around with vestibular symptoms and they do not have a clear diagnosis as to where's the pathology, what's driving it, and what is the actual diagnosis.
It sounds like some of these issues, they're annoying, but they don't stop people from living their life. It's just kind of a thing that puts a drag on what they're doing.
Yeah, some people think that they have to live with those symptoms, and so they just kind of put up with them, and
they put up with it. I got a question here. The difference between dizziness and vertigo. In a lot of people's minds, especially a lot of patients, mine too for that matter. Look, I'm not a neurologist and, I don't have the same kind of specialities that you guys do. What's the difference between vertigo and dizziness?
So vertigo is a sensation of rotation. So a true vertigo is a sense that either the world is spinning or rotating around you, or that you yourself are spinning or rotating. And that might be when you are at rest and not moving that you feel this rotation, or if you yourself are moving, you may have an illusory sense of an exaggerated rotation. So the term vertigo means that there's an element of rotation or spinning. And then you can have more of those non-vertigo vestibular symptoms like the rocking, the bobbing, the swaying. But when someone is dizzy, dizziness is more of a sense of feeling disconnected from your environment, but there's no sense of rotation or spinning.
Yeah, and just to add to that and to tie it back to TCM a little bit more, dizziness can have the etiology of just also being blood deficient or not having enough circulation, whereas vertigo would not have that factor, meaning just because someone has less blood volume or is blood deficient, they're not going to necessarily get that vertigo kind of sensation, but dizziness can have those factors tied into it. So they start to differentiate a little bit in that way. And a lot of what Ayla is talking about, it's to help put some flag posts in for all the viewers or listeners. When we talk about the vestibular system, we're talking more of like the gyroscope of the body, trying to keep more upright, in which case I would lean treating the gallbladder meridian around the head and the ear area. Whereas when we're talking about that cerebellar deficit or the spinocerebellar issue, then when you watch someone walk down the hall, if they're taking steps that are uneven and different lengths or not like straight, some are short, some are long, some are wide, instantly you can think, okay, that's the cerebellum that's not making the correct measurement of what each footstep should be, because it's supposed to even out the antagonistic muscles. But if the person's turning, right, and they turn and they spin and they lean over, as Ayla said, in different ways, now you're looking at the gyroscope. See what I mean? So, like, if you're going to treat the cerebellum, you can go down the bladder channel, get into UB, do some of the Huatojaji points into the neck if you want. Whereas when you're trying to reset that vestibular, and just to tie it in together, the vestibular ocular motor reflex, which is what she's getting to, then yes, you're right in what you said earlier. Do we need to go more local? Yeah, sometimes just to affect the eyes, you do need a needle Taiyang or UB2. And then, interestingly enough, you'll see a lot of these really amazing deficits of the eye start to like smooth out, and there's an art to it. And it's almost like when we talk, we had to really see and correlate. But like as you do start to play with it and start to add those kind of points, you can see that the eyes can actually start to smooth out, focus, get their targets, and then you can have all these different types of vestibular or balance cases start to clear up, and then you'll really like, it'll be like the Kool-Aid. You'll be like, wow, that was neat. I want to do another one. Like it's like it's addictive.
Well, and once you see it, I know that this is that now. It gives you some extra data points, and then you start noticing other things beyond that. So with that in mind, I have noticed something about patients for a long time now. This is kind of simple. Maybe this plays in here, maybe not. Let's find out. Some people, when they get on the table, they know where to put it's like they know how tall they are and they know how tall the table is. They see where the pillow is on the table, and they just like sit on the table. They know where to put their butt. They turn, lay down, bang, head right on the pillow. There are other people, they just cannot aim their head at that pillow. They miss it here, they miss it there. Some overshoot, they tend to overshoot. Some tend to undershoot. This is diagnostic information, isn't it?
It is, absolutely.
This is your inner functional neurologist speaking, Michael. This is your inner, right, Ayla? It's his inner neural voice coming out.
Yep. And how people, like watching people turn over, right? Like you treated them laying face down, you have them roll over, and you watch them do like a 20-point turn just to like flip over. And then their head is like hanging off the table and they don't even know, oh, maybe I should move down. And it's like you're witnessing people not knowing where they are in space.
Mm-hmm, exactly.
And so that could be a vestibular issue, or it could be a parietal issue, because in the parietal cortex, we have an area called the PIVC, the parietal insular vestibular cortex. And that's like a sensory hub of integrating all that information of like, where is my body in space based on my own internal maps? And then what information is my vestibular system telling me? And what are my eyes telling me? And so, yeah, so like that kind of, objective finding where you're like, this person doesn't know how to move their body on this table in a way that makes sense, is an indication that maybe they have really poor like body mapping, poor spatial awareness. And it could be a vestibular issue, it could be a parietal integration issue of that vestibular information, but it's all very important to be able to see that.
How could I take this basic finding that I see? Sometimes they also just like lay a little diagonal on the table. They're not centered, right? There's that too. how could I take this basic information? I don't have all your tools or your background, but it's just kind of a, common garden variety acupuncturist that I am. How could I begin to think about this, bring it into my diagnosis, maybe ask some questions to see where it's come from, or maybe add some treatment to see if it might help some of the other issues that they've got that might be downstream from this kind of a problem?
Yeah, I mean, you could start to ask them questions that I like to say are indicators of parietal dysfunction. Like, do you get lost driving around a city that you actually know very well? Like, are you getting lost while you're driving? Are you having trouble with driving directions? Do you get your rights and your lefts mixed up? Do you like bump your shoulder into door frames when you're walking around? Like, are you clumsy? You can start to ask people just questions on basic spatial awareness of their body, but then also like navigation. And then you could ask them more of the vestibular questions. It might clue you into maybe if you know how to do a vestibular assessment to like put someone on a phone, to look at the difference between their balance if they're standing on the ground with their eyes closed versus what happens if you stand them on like a foam pad or a squishy pillow and their eyes are closed. Because when you have them on what we call a perturbed surface, you're taking away the ankle proprioception of them being on the floor. And when you close their eyes, you're taking away vision. And what you're left with is their brain trying to use their vestibular system to maintain balance. And so sometimes you'll see that people can stand on the ground with their eyes closed just fine. You get them on a squishy foam pad, and all of a sudden they're falling all over the place. So there's sometimes these little things that you clue into on the table could guide you to say, maybe I need to do some more tests. And then I also think that acupuncture is a great tool to remap the body. So when we have poor body maps, we're actually helping all of our patients every day by doing acupuncture and improving that brain-body connection. And then a lot of times I like to do 2 different exercises. I'll take their limb, like when they don't have needles in, and I'll do just some very gentle figure 8 movements of a right arm and then a left leg and then a right leg and then a left arm. And I might have them like think of animals that start with the letter C while I'm doing these kind of figure 8 movements. And so I'm remapping the body by activating the cerebellum and bringing in a cognitive task at the same time, just to kind of create more brain activity in general. And then I also like to do kind of what I call a body saccade activity, where I'll have the patient close their eyes and I will just touch different joints or body parts, but I'll move from up to down and right to left. And so when I touch a right shoulder with their eyes closed, they have to move their eyeballs to the right shoulder. And so they're just moving their eyeballs in the direction that I'm pointing, and I'll, touch their forehead. They have to move their eyeballs up. I'll touch their right cheek and they move their eyes to the right, or their left big toe and they move that direction. And by using their eye movements with proprioceptive input, that's another really gentle way to kind of remap the body.
In clinic, there's no such thing as a small detail. The needle you reach for, the formula you prescribe, the moment you choose to listen just a little bit longer. Your patients place their trust in you, and you deserve to place the same trust in the tools that you use. At Blue Poppy, they hold their products to the same standard that you hold your care. Herbal formulas crafted for efficiency, needles that perform the way you expect them to, clinic essentials that arrive on time. Because when your tools are dependable, your focus stays where it belongs, on your patients. No guesswork, no compromises, just steady support behind the scenes. Blue Poppy, the choice of practitioners since 1982. Literally hooking themselves back up. I was just thinking here, if anyone has a Tesla automobile and they bought it new.
Yeah. Yeah, and also just to add to that,
when you first drive it, it has no mapping, right? I mean, these cars will actually drive themselves. But for the first period of time, it has no mapping. And it has to run through the environment to see things before it knows where the map is. And then, with time and repetition, it builds this internal map. I'm thinking, okay, this is a computer system that's mapping things, but in some ways our body is also a system, a dynamic organic system that maps where things are. And if our map is too far off from reality, then it's really hard to make sense of reality. Acupuncture resets that. You're just talking about using these body exercises. Are there other ways of remapping that you found helpful?
I mean, there's tons of ways of remapping the body. I mean, there's a lot of movement therapies like Tai Chi. Tai Chi is one of the best ways to remap the body. And so things like Tai Chi, Feldenkrais, Pilates, all of these exercises that have you really increase your awareness of exactly how you're moving are phenomenal for remapping.
Okay. Clayton, was there something you were going to say there? I feel like I cut you off.
Yeah, I just wanted to add that as you do those tests for the vestibular system, just for everyone to start trying to put this into practice, let's say if the left side or right side comes up positive on whatever test you're trying to do, just start palpating the parietal, temporal, occipital areas of the head and the neck. And this is very simple, but do it this way. Just make a note in your notes of like, well, which side had more tension or which side had more swelling. And it's gonna allow you to cue in and see and then tie in a lot of this information we're giving you because you need these little like directional posts just so you can put it together in your head, and sometimes that's how we just figure it out. You make a note of it, but you notice, okay, and that tension area, for example, when it's behind the ear, little posterior but above GB20 into the GB10 area. If someone had vertigo, for instance, instead of being that alpha CEO, okay, it's kind of hard here, it gets really rigid. There's like rigid lines that appear. And when I see that and I palpate here and I see these almost like a conch shell shape of rigid lines, I know without them speaking to me and without me asking the question, I know that they're getting vertigo and that they're very off balance. So that automatically puts me into a fast track in the direction of the treatment, And everything that we're talking about, what's really important is when you now know, okay, I'm dealing with a neurological case, I'm dealing with concussion or some brainstem injury or something like that, frequency of treatment is really important. They can't come in once a month. They can't come in once a week. They need to come in at least 2 to 3 times a week because now you want to remap the body. Now you got to reset the nervous system and it's already in the wrong holding pattern and it's keeping itself together.
Right. It's compensated itself into the problem that it has.
Right. If you only treat this person with whatever modality once a month, you're maintaining the wrong pattern. You now need to reteach it. And then the body has to recognize I've been on the wrong setting. I have to recalibrate to the right setting. Take the Tesla back.
This is really interesting. Treatment that's not frequent enough not only won't change it, but it will help lock in this homeostatic level that they've got. It's not optimal.
Exactly.
A lot of times homeostasis does not mean optimal. It just means this is the mix we have and this is the set point. And the body wants to stay in that unless it's, forced out of it or somehow healed out of it.
Yeah, it's in neurology, it's called coupling.
Coupling.
So the nerve will actually maintain the wrong setting. And sometimes it'll create extra wrong branches, maintaining that wrong setting. And that happens a lot, for instance, with facial paralysis, with the cranial nerve 5 and 7, trigeminal and facial, the person will start getting these extra symptoms of like whenever they smile, their eye will close, and so these different functions start coupling together. You cannot change this person treating them once a month. You have to start treating the areas and keep exposing it to the new sensation with acupuncture, with the exercise. You could do facial yoga, whatever it is, but you have to make the person take the initiative and start changing how the person's using their own neurology even. And that's the beauty of a lot of what Dr. Wolf is suggesting here, because she's telling you step on an uneven cushion because that cushion will change the way your brain is standing on the floor. Or sometimes Dr. Wolf will put someone on a rotating chair, right? I'm going to steal one of your moves here, Ayla. Have them look at an object, rotate the chair while they're still trying to look at the object. And that's like challenging like 4 different cranial nerves, 4 different systems in the head, the ear, the eye, the gyroscope, the parietal lobes, everything, So like it's such an interesting tool, but it can be used as a diagnostic tool or it can be used as a treatment tool too. And that's what I do like about a lot of what we teach and what we do. We'll take the tool, we'll refine it. Now I'm going to use it as a treatment. Okay. Now I'm going to use it to see where you're at, and how well you know your instrument is how well you can use it in different ways in your practice too. So
For sure. I want to come back to something Ayla was talking about a few minutes ago. You mentioned the word migraine, and I hear the word migraine in my clinic a lot these days. It's often something my patients will say as part of their diagnosis. They've got a blah, blah, blah migraine. They got a this or that migraine. It's not like the migraine behind the eyes, headache kind of migraine that people often come in with, the one that everybody knows about. But it's a this or that a migraine, or some, it's like some adjective on the front or a noun on the front, migraine. And it surprises me to hear these diagnoses coming in. I haven't really studied them. It sounds a little bit like a wastebasket diagnosis. Like, well, we're not sure. It's this weird neurological something that isn't debilitating, but it's bothersome. So it's an XYZ migraine.
Yeah. So I've been working really hard on, I had taught a course on migraines a while back. It was 2 hours long. I've now turned it into probably like a 14 to 16 hour course. So
My goodness.
I've really expanded it. And so I've included a lot of these subtypes that you're talking about. And so what we need to understand is that a migraine, like even the classical migraine that we're all familiar with, it is so much more than just a type of headache. It is an altered brain state it's a sensory processing disorder is what it is. And so when we start to look at it as a sensory processing disorder, it starts to make more sense why people have the light sensitivity, the sound sensitivity, the smell sensitivity, why stress makes everything worse. The brain is very sensitive to changes in hormones, so there's often a hormonal component to it. And so we have all these different subtypes of migraine. We've got our classical migraine, we have our migraine with aura, we have hemiplegic migraines, we have ocular migraines, we have retinal migraines, we have abdominal migraines, we have vestibular migraines.
Abdominal migraines?
There's a whole category called abdominal migraine. And so some people will immediately get this sense of nausea. And so one of my other people who works for me has a abdominal migraines, and I was laughing so hard because she said, "Here's how I know I have an abdominal migraine. If the thought of eating pizza doesn't make me want to puke, I have an abdominal migraine. If the thought of eating pizza makes me want to puke, I know I have food poisoning." And I was like, okay, you are hilarious. But so the other thing is that what we need to recognize is that all these different manifestations of migraine all come back to a dysregulated brain physiology, often involving the autonomic nervous system and also cortical structures. So abdominal migraines might be considered a hyperactivity in areas of the brain where all that vagal nerve information kind of dumps into the brainstem, that the vagal nuclei in the brainstem. A vestibular migraine represents more of this instability and hyperactivity in the vestibular nuclei of the brainstem, whereas a classical migraine is a dysregulation within what's called the trigeminal cervical complex in the brainstem as well, that's transmitting pain signals regarding the head to the brain. And then when you've got these like hemiplegic symptoms or the aura, that's called a cortical spreading depression, where it's literally like if you think of a power outage in a city, like it's never like simultaneously everything goes dark, right? It's like a wave that goes through the city and it's like right? That's what's happening in the brain. It's like this cortical wave of depressed brain activity where all of a sudden somebody has paralysis on half their face or in their arm or their leg, and they can't, like, they have all these, negative motor signs of paralysis. And so the aura itself is a cortical spreading depression that then creates all of the scintillating visual stuff. So I think that, from my perspective, the more I learn the neuroscience of things, the more valuable I am to my patients, because I'm not confused about what's going on when they come in and they say, half my face is paralyzed. It's like learning the neuroscience has just made me a much better practitioner of traditional East Asian medicine, because I'm not confused by what walks in my door when it sounds strange and weird and funky.
It's not just liver winds.
There's a lot more to it.
Mm-hmm. How would you begin to approach some of these unusual migraine situations? Would you use your Chinese medicine diagnosis? Would you use your Western neurological understanding? Where's a good place to begin? Because again, increasingly I'm seeing patients come in with this kind of a diagnosis. I mean, maybe I need to take your 14-hour course to be able to understand it. But for the listeners that are tuning in right now, what are a few small steps that we might consider in approaching treating this kind of thing?
So there's a lot of levers that you can move to help these patients. I think that one of the things that we maybe do accidentally as acupuncturists is we're trying to, we overstimulate people by just putting in too many needles. And what I have found.
Yes. And I'm curious to hear your point of view on that, because I think overtreatment is something that happens more often than we like to think about. And so I'm very curious to hear your perspective on this and how to avoid it and what to do about it.
Yeah. So the Ling Shu basically says that when you have a unilateral headache, you should treat the Yang Ming and the Xiaoyang channels on the arms and the legs. And so there was this great research paper where they gave people with migraines 20 acupuncture treatments. And it was like each group, there were 3 different groups, and each group had a combination of only 3 acupuncture points, like 1 on the hand and 2 on the legs. And we're talking maybe like stomach 36, gallbladder 34, and LI 6, for example, or like triple warmer 5, gallbladder 43. So there were 3 combinations of 3 points, either on the Yang Ming or the Xiaoyang channels, and they were doing fMRI images of their brainstem. And what they found is that by doing those 3 points in all of these groups, it modulated the activity in that trigeminal cervical complex in the brainstem. And so I've taken that research to heart, because I know that when you have people who are so unstable from an autonomic perspective, if you start doing a bunch of needles in the head or the suboccipitals, you can throw them into a migraine real easy. And so what I have literally started doing more and more with these patients that are highly unstable is distal acupuncture points, Yang Ming, Xiaoyang, keep it super basic, and the results are actually quite lovely. And so it's
a few targeted points to help calm a system that's already dysregulated, as opposed to a bunch of points that make the dysregulation maybe even worse.
And those are the patients that'll say, okay, take all the needles out. I got to get off the table. Too, like when they're just over.
If you do too much.
Yeah, they're just hyperactive. They're overly stimulated. Too many needles will actually set them over the edge too, right?
It's good to know. Well, we started with concussion, but wow, we've traveled into some other really fascinating territory. And I think the pathway here is neurology. You guys, the way that you look at neurology from a Western point of view, from a East Asian medicine point of view, the way you're putting it together, it's really a fascinating pathway. Anything else that you'd like to share with our listeners before we wind it down for the day?
Well, Clayton is working on a book for his skull palpation technique. So it's going to be very exciting when that comes out.
Yeah, hopefully it'll come out towards the end of the year or beginning of next year, but it'll have the special anatomical like pictures showing where to palpate, what the pattern will look like on the head or skull, and it'll actually tie in a lot of how we're talking in this conversation. Okay, which neural mechanisms are involved, which meridians I'm going to use, which points and which maybe herbal formulas I can use for this skull pattern, and that way it'll just help the learning process better. And also, like, I'm doing this because I just feel like acupuncturists can be at the forefront of being the new generation of neuro functional practitioners. And we have so many, like, thousands of years of detail and techniques, and it's just a new way of stitching together how do we apply it. So in fact, anything we said today and anything that we teach, it never devalues TCM or meridians. It actually elevates it. Actually, almost confirms the wisdom and genius of it, you know? And also, I think it'll be on the website soon, but coming up in June, we're going to together teach a Parkinson's and neurodegeneration workshop. So we're going to, because that's a big thing of, it's not just nervous system injuries like a concussion, but it's also over time, how do we maintain or how do we treat neurodegeneration in the body as we age and stuff too. So we're putting together a pretty amazing hands-on workshop to help you see it, help you differentiate things like Parkinson's and tremors, and also how do you maintain the nervous system and the brain too. So it's gonna be listed on the Nanopuncture Seminars website soon. So yeah.
Okay. We'll put a
I think, what I just want to piggyback off what Clayton said, which is that having the knowledge of the neuroscience does almost, like, for me too, I really feel like it just validates our medicine. And one of the things that I've been studying a lot lately is postural orthostatic tachycardia syndrome. And when you start to recognize that within POTS, there are multiple subtypes of POTS in terms of what's actually driving the tachycardia. And so by understanding the pathophysiology of postural orthostatic tachycardia syndrome, you start to become a much better herbalist because you recognize that some people have what's called hyperadrenergic POTS, which is when they stand up, their body releases norepinephrine. And so then they have an elevated heart rate because of the norepinephrine. And in that case, those people usually have a lot more heat signs. They often have migraines, and they might actually have high blood pressure when you do a tilt table test. So they've got the elevated heart rate and the high blood pressure. And so you would want to treat that person with like a Chai Hu Longu Muli Tong or something that really calms the Shen and anchors the Shen and is cooling. But then you've got hypovolemic POTS where somebody actually has low fluid volume. And in that case, those are the people who, when they stand up, because of the low fluid volume, they have tachycardia as a purely compensatory mechanism. And that person probably needs like a Sheng Mai San to generate fluid. And so once you understand the pathophysiology behind the subtypes of POTS, you start to recognize, wow, I could really make somebody worse if I don't know this information. And I don't want to give somebody with hyperadrenergic POTS a warming formula, and I don't want to give someone with hypovolemic POTS a tonic without first dealing with the generating the fluids. And so for me, it's like the more I dive into this, the more Chinese medicine becomes this brilliant system to help these people.
Yeah, that has an answer for for all these things. And just to put it out there too, with all this terminology and new techniques that you're hearing about, Ayla actually did write a book called The Concussion Breakthrough, and it's like this thick. It's about 600 pages, but it actually talks about everything we talked about in different chapters. It was meant for the patients, but honestly, it's an amazing reference book if you are stumbling into these topics or categories, and she wrote a chapter for almost everything we discussed and more. And also, she has her own amazing Concussion podcast where she'll even invite people that have made new devices onto her show, and they talk about, oh, this is a laser headset, or this is a an earphone for this, and it's an amazing reference for practitioners or people that want to learn more about the concussion um, world. It's like the new Cobra Kai. Like how Cobra Kai expanded Karate Kid universe. It's like her concussion podcast. I don't know where she's getting all these amazing experts and guests from around the world, and I'm just like, how did you know? How did you meet this person?
Well, she's kind of a neurology geek, and so you hang out with other neurology geeks. That's what happens. Look at us, Chinese medicine geeks.
Yeah, exactly. Well, yeah.
Look at this conversation. One of the things I really
Neurological brings everyone together.
One of the things I really appreciate about this conversation today is looking at how, I think, Clayton, you said it, how this information actually informs our medicine, informs much of what we know. Ayla, I appreciate all the Western neurology that you've gone into very deeply, all the functional neurology you've gone into, because the cool thing about East Asian medicine, look, we got all this wonderful historical stuff and pulse and tongue and palpation and, this and that, quotes from the Ling Shu. But the thing to me that's most amazing about acupuncture is we can grab any handle. We can find different kinds of markers that help guide us in the work we do. And so what you were just talking about with, is this an issue more of qi or of like lack of fluids? And that's the reason someone's dizzy. Is there fire? Is it fire or is it fluids? And we can take very, very modern ways of looking at the body and overlay that on the medicine that we practice and see things come out in 3 dimensions and go, here's a good place to begin. And that, I think, is one of the really exciting things about what you two are up to with this stuff. So I really appreciate you taking time out of your busy schedules to sit down and jibber jab about it. I've learned a lot, and I suspect our listeners have as well. I'll make sure that your information's on the show notes page. So some of the things that we've talked about in terms of classes or books, that kind of thing, folks, all y'all just go to the show notes page on Neurological. You'll be able to click right through to it. And again, you guys, thanks so much for joining me today.
Thank you. This was awesome.
Thanks for inviting us. Yeah, it was a lot of fun.
Well, that was quite a ride, huh? I feel like I might need an eval on Ayla's tilt table after trying to process all that's been discussed here. There are a few key takeaways for me about head injuries. First, concussion has moved into the public view in a very different way. Some of that is culture. We're paying more attention to it. We've got more tools for assessment, and so more language to map the theoretical landscape with. As with so many things, when you know more, there are more ways of noticing when something isn't right, which in some ways is the strength of East Asian medicine. We have ways of paying attention, and as Clayton discussed, there are palpable changes you learn to feel with all kinds of neurological conditions. I was surprised to hear about whiplash as an issue that would show up later. And thinking about the neck as both a support for the head, but beyond that, it carries sensory information about how we relate with gravity and being upright. It kind of gives a whole new meaning to UB10, the heavenly pillar. There was a time when the cells of the brain were considered not to be able to reproduce. Once they were gone, they were gone. But now the idea of neuroplasticity and that the brain can change itself, it's quite in vogue. I usually think of that as a good thing. But in listening to this conversation, it seems that sometimes the brain's attempt to compensate creates another stream of problems. Neurological health, much like gut health, are fascinating frontiers of Western medicine. And I'm encouraged when I hear practitioners working at the intersection of modern biology and East Asian medicine. For sure, if you have an interest in neurology, following Ayla and Clayton's work will take you into some interesting territory.